Hi. Hi, everybody, can you hear me?
Yes.
Okay. So good evening, everybody. Okay. Welcome to joining us for the webinar of APAGE and English. So I'm Dr. Olark Musigavong from Thailand. Today I'm a chairman of this webinar, and my co-chair, Dr. Relly, will come later. So don't worry, we will start the webinar from now. Don't worry. So I would like to introduce Professor Zhang Lian. He is the director of the Haifu Hospital. Professor Zhang Lian, so please, over to you.
Thank you, Olark, and dear my friends, ladies and gentlemen, good evening. I'm very glad to have the chance to meet you here, and we are glad to see that the COVID-19 pandemic is better controlled with the increasing rate of vaccination and other measures taken. We are already seeing the light at the end of the tunnels. So last year, we have organized 8 webinars and 1 international Women's Day event. These webinars focus on laparoscopic technology and Haifu to solve problems in the management of gynecological diseases, malignant tumors, improvement of the health of African women, and also fertility preservation. And the International Women's Day event connected 128 hospitals globally to perform Haifu ablation for 128 patients on that day as a public benefit activity. The International Society of Minimally Invasive and Virtual Surgery worked jointly with the International Journal of Hyperthermia last year to publish the first Haifu special issue in August. The 14 articles in this special issue cover common subjects such as Haifu ablation for uterine fibroids, liver cancer, pancreatic cancer, and some newly expanded indications such as desmoid tumors, recurrent ovarian cancer. A meta-analysis compared the efficacy of Haifu, UAE, and myomectomy on uterine fibroids, and also Dr. Lee from Singapore shared Asia perspective on Haifu. So experts from UK, Germany, Spain, Singapore, and also China were shared this experience in these articles. Unfortunately, we have to postpone the annual meeting of Young's International Summit of Minimally Invasive and Non-Invasive Medicine together with the board member meeting for another year. However, our academic discussion will be continued for online webinars. Please follow us to know our latest webinars. We are happy to announce that we have decided not to postpone our training workshop on Haifu for another year. Instead, we will change the training site from Plaven, Bulgaria to Malacca. So to make it happen in November 2022, this year, for doctors who are interested in this workshop, please contact our secretariat. Knowledge is infinite, and there is no end for learning. Even if we are facing a lot of challenges, the International Society of Minimally Invasive and Virtual Surgery will continue the learning and deliver our ideology together with the new knowledge to our colleagues. Thank you very much, and good night.
Thank you, Professor Zhang Lian. Can you hear me?
Yes.
Okay, so for the next speaker, I think all of us know he's the world-known. It's not only in Asia Pacific, but it's all over the world. Professor Chyi-Long Lee. So he will talk about how does the endometriosis DIE impact on fertility. He's a professor from Chang University. He's board of trustees of the APAGE, and he has a lot of the how I say, the experience, not only for surgery, but also on the academic, how to do the laparoscopic surgery. He has the student all over in the Asia and all over the world. So please, Professor Chyi-Long Lee.
Hi, thank you. So, Olark, and I think that today is very meaningful. Yeah, because the minimally invasive with the non-invasive surgery, I think that is we can have some spark and discussion about what Haifu can do for the endometriosis and also what the laparoscopic surgery can have Haifu to complete some work. Maybe Haifu is not well established. So I think the meeting is very meaningful. I hope all of you will enjoy all the talk, and I hope you can join the next webinar also, because the 4 Haifu webinar will be all very fruitful in your career. And so thank you very much for your introduction, and let's begin my speech. Thank you, Chairman. Thank you, Dr. Olark, and also thanks Dr. Relly for your kind introductions. Today, I want to talk about how does deep endometriosis impact reproductive outcome. The deep endometriosis is a very troublesome hard work for the gynecologist. I'm very pleased to announce APAGE-HIFU and the Chongqing Haifu have a joint enterprise agreement for the promote minimally and non-invasive therapy. And I'm also the chairman of board of trustees. In the 2017, we have a very successful annual congress in Okayama, Japan. And 2018, we have the annual meeting in Surabaya, Indonesia. Ready? Thanks for your hard work. And in 2019, we have a 20th annual congress in Chongqing, China again. It's a very successful meeting. The participants, more than 3,500 people there. And in 2021, APAGE 21st Annual Congress in Yokohama, Japan is also a very successful one. They have more than 3,000 participants in this Congress. And this year, the annual Congress will be in Taipei, Taiwan, from the September 30th to the October 2nd. Welcome you to join us. I'm also very pleased to announce our fine journal, GMIT, Gynecology and Minimally Invasive Therapy. They have a very high impact factor. The impact factor is 1.3 in 2021. I expect they will have some more increase in this year. Welcome to submit your fine paper. Today, we want to talking about the deep endometriosis. Actually, the endometriosis in reproductive women is quite a lot. They estimate have a 10% in women in reproductive age. So about 176 million people suffer from the disease worldwide. So the incidence in asymptomatic women is 2 to 11%. In infertile women, they have 5 to up to 50% have endometriosis. The women hospitalized for pelvic pain, they're up to the 21%. And I want to give you an example. The IVF treatment without a diagnosis of the deep endometriosis or endometriosis not only decrease the ultimate clinical practice rate, and it also have a not without potential serious adverse effect. So we can find the paper from GMIT last year's, a case of an abscess, cystic endometriotic lesions in the vesical uterine pouch after oocyte retrieval. It's quite rare. Most of the TO abscess will happen in the posterior cul-de-sac, but this one is in the anterior cul-de-sac after oocyte retrieval. The paper is from the Dr. Chicago from Japan. It's a 31 years old non-polyps woman visited the clinic due to the worsened dysmenorrhea. So a cystic endometriotic lesion was found in the vesical uterine pouch. Her first oocyte retrieval attempt was performed at IVF center before the planned surgery. And he complained of abdominal pain on day 6 after the retrieval. So Dr. Chicago diagnosed with the peritonitis with an abscess, cystic endometrial lesion in the vesical uterine pouch. And so they give them the conservative treatment 2 weeks, but ineffective. So operation was arranged. The cyst of the vesical uterine pouch was drained out. And so they make conclusions. The presence of endometrioma could be a risk factor of developing ovarian abscess. Also, the small pool of the old blood clot act as a medium for growth of the bacteria that have the transvaginal inoculate at the time of oocyte retrieval. This bacteria can easily grow in the cyst and cause pelvic abscess. So the GMIT published the data about a case of an abscess cystic endometriotic lesions after the oocyte retrieval. So in mild and minimal endometriosis, the mechanisms of mild and minimal endometriosis with the infertility, because they have a toxic effect on gamete, embryo, and impair of the tuber motilities. And also endometriosis imprint secrete pro-inflammatory cytokine, just like the interleukin-1 beta, interleukin-8, interleukin-6, and also the TNF-alpha, and also the estrogen and progesterone, which attract macrophage and the VEGF and the interleukin-8, thus create an inflammatory status impaired the fertilities. Secondly, they have a normal follicular environment, and because of height in cytokine, and also they have an inflammatory status. So also they have a enhanced ability of the phagocytosis, the sprint by the peritoneal macrophages, and a reduced rate of the fertilizations. So of course they will make infertilities, and an impairment of implantation rate, and also the endometrial receptivity. Moreover, for the moderate and the severe disease, they can have an impairment of the oocyte relief because of the adhesions of endometriomas. The oocyte retrieval or oocyte relief sometimes is very difficult. Also, an impairment of the tube transport because of the adhesion formation, sometimes have some phimosis of the tube, and also breakages of the sperm migrations. So they have interfere the oocyte and the sperm join together. And what is the best choice for the treatment, medical versus the surgical treatment? Or maybe we need both, but what comes first? Here we will discuss about what will be the best choice and what comes first. First, if the patient have a high risk of the ovarian cancers, in these situations, to have the tissue approved is very important. So that is the patient should have received the surgery. We should note the risk of the ovarian cancer in the patient with the endometrioma. Although they are not evident that endometriosis caused cancer, but some cancer are slightly more common in women with endometriosis, just non-Hodgkin lymphoma and ovarian cancers. And a higher risk of the histologic subgroup of the ovarian cancer, significantly increased risk of the clear cell ovarian cancer. The odds rate is 3.05, and the low-grade serous ovarian cancers odds rate 2.11. The endometrial invasive ovarian cancers odds rate 2.04. They have some endometriosis impaired, some data concerned about the endometriosis impaired fertilities. Normally, the monthly fertility rate is about 15 to 20%. But the patient with endometriosis, they will decrease the monthly fertility rates to 2 to 10%. And also, they will impact the ART outcome. They have a 7% decrease of fertility rate in stage 1, 2 endometriosis. And they have 21% decrease in the stage 3, 4 endometriosis. And also, they have a low oocyte retrieval rate in the stage 3 and 4 endometriosis. And also, they have a consensus for the endometriosis. The surgery for women with symptomatic endometriosis for pain or recurrence, laparoscopic surgery removal of endometriosis is an effective first-line approach for the treating pain related to the endometriosis. And also, the laparoscopic surgery for the endometriosis should always be undertaken in prevalence of the laparotomy when possible. And the cystectomy is better than just the drainage to minimize the symptom recurrence and the endometrioma recurrence. Should surgery be performed for complete removal of endometriosis before the ART? Before ART, diagnosis and laparoscopy when performed, the complete removal of the lesions is quite helpful to increase the higher implantation rates and the pregnancy rate and live birth rate in the patient that have a complete removal of the endometriosis. So in the stage 3, stage 4 endometriosis, if you have a removal of the lesions, they have a much higher of the pregnancy rate, spontaneous pregnancy rate up to the 57 to 69% versus 33% in patients with the moderate endometriosis, and up to 52% to 68% versus 0% in severe endometriosis. So we can find in stage 3 and stage 4, they increase much higher in the pregnancy rate when compared with the not treated group. How about deep endometriosis? Deep endometriosis is one kind of the endometriosis, not the same with the superficial endometriosis or endometriomas. Deep endometriosis have about 1% in women in the reproductive age, about 10% in the patient with endometriosis. According to the anatomic, they will involve vaginous, urosac ligament, bowel, bladder, and the ureters. So the deep endometriosis also impacted the fertility because they have some adhesions, and also they have some superficial imprint, and also have endometrioma formations, and sometimes they have getting the adenomyosis. And also they will coexist of other type of endometriosis, and they will produce of the inflammatory cytokine and the chemokine. So it will interfere with fertility. And it's also they have a poor follicular genesis. Because of the poor follicular genesis, so they have a fewer oocytes can be retrieved. And also they can have adenomyosis formations, and they have many different forms, includes in the connecting ligament, urosac ligament, and also in the cervical vesical ligament. And also reduce the endometrial receptibility and reduce the endometrial receptivities. Also, they can have some hormone receptive functions, and also they have make the immunology factor have a peritoneal macrophage increase, and the natural killer cells appear in the peritoneal fluid. So in the patient have colorectal deep endometriosis, they estimate they have about 5 to 25% with endometriosis. They have an intestinal involvement, and the colorectal deep endometriosis sometimes present with a subocclusive or occlusive of the bowels. So they have a some bowel syndrome and obstructive bowel syndrome. And the pelvic endometriosis have a significant rate of 2.6 of bowel obstructions. And the intestinal endometriosis was associated with the 14-fold of increased risk of the bowel obstruction, with the rectal vaginal endometriosis associated with the 2-fold of increase of risk. So the overall prevalence of the bowel obstruction about 1%, and 27.9% of women with colorectal DIE have progressed as seen by MR over 3 years period. So most of the deep endometriosis, 1/4 of the women suffer from the progressions of the deep endometriosis. How about the endometriosis with the urogenital tract? Deep endometriosis may present in renal failure because of the urinary tract obstructions. And so whenever they have the deep endometriosis, you should evaluate the GU tract. And also the majority of the patients with the deep endometriosis have the severe pelvic pain. So the surgical intervention is indicated. But we should remember, evaluate the GI tract and also the GU tract. And also you got the history of the previous surgery is a marker for the severity of the disease, especially for deep endometriosis. And 78% of the patients with the deep endometriosis have a previous surgery of endometriosis, which may allude to a possible elevations of the disease by incomplete surgery. So the complete surgery of the deep endometriosis is a very important work for the gynecologist. So we note the deep endometriosis in the situation we need to perform the surgery. Just like the severe pelvic pain, they have unresponsive to medical treatment, and they have the obstructive uropathy of the have symptom of the bowel stenosis, or they have a risk of ovarian cancers, or the patient they have a reproductive design. So here we show you a patient, they have a bladder endometriosis. We can find in the sonography, they have just a mass on bladders, but on the cystoscope, we can find a growth, pupilar growth of the neoplasm in the cystoscope. So here, we just open the anterior ligament and open the parietal space and identify the ureter. And then, after the anatomy have been identified, we attack the lesions on the bladders. So here also have a adenomyosis of the round ligament here. So we excite the adenomyosis on the round ligament and also identify the ureter. And the uterine basal have been coagulated and dissected because they have several applied in the artery, so the ascending branch of the uterine artery can be coagulated and dissected. So here we can identify the lesions, and the lesions is about 4 centimeters, and the schistotomy was crossed by the 3O micro, the 2-layer sutures. And before the suture on the bladder, we have put the double Z on the ureters to identify the ureter. And the second layer suture was complete also by the micro. And then the round ligament have a attachment by the one micro. So sometimes it's a silent the bladder involvement, but most of them we can see just under the cystoscope and do the biopsy. And then on the side, on down, we can direct resections, but on the base, we should dissecting the vesical uterine space and resect underlying myometrium because of adenomyosis there. So again, we see the patient, they have a deep endometriosis when severe pain, when obstructive uropathy, we have to do the surgery. But in the reproductive design, shall we perform the surgery? Because of the controversy issue, when we look at the deep endometriosis, they may catalog in the minimum of severe endometriosis. So in the HS, when they got the minimum or mild endometriosis, complete resection may improve the art and the spontaneous pregnancy rate. But sometimes in the deep endometriosis, you can identify just before the surgery. So actually, the DE may catalog in the minimum or severe endometriosis. Just like you have a 3 centimeters deep endometriosis because just a catalog on the peritoneum. So you just get the scope of 6. So it's a mild endometriosis. But this 2 to 3 centimeter, they maybe just have a scope 4. So they have a minimum endometriosis. So you perform the resections? Of course, if you can't. Again, sometimes just like we have shown you the 2 cases in the beginning, we do the IVF without diagnosis of the DE, decrease the optimal clinical friction rate, and not without potential serious adverse effect also. So there is a very fine journal, the GEMIC. They have the Gamma, Dr. Gamma have a published data review article and a systemic meta-analysis from the 150 article. And lastly, they have a 4 included in the study. They have a DIE surgery, compare the DIE surgery before the IVF and with the complete or incomplete surgery or subgroups with the bowel involvement or not. Finally, they're looking for the complication and the data regarding safety of concern. So the result of the deep endometriosis patient before IVF, according to the systemic review and the meta-analysis, we found the surgery before IVF, if they have a digestive involvement, they have the out rate 2.4. It's favored by using laparoscope to do the surgery before IVF. And DIE without digestive involvement, the out rate is 1.55. So even in the incomplete surgery group, they also showed a higher pregnancy rate odd rate is 1.63, and the critical rate per patient was 1.84, and the live birth rate per patient was 2.22 times more likely to operate patient than for the non-operated one. He made conclusions is that they have a statistically significant benefit for surgery before IVF, although they should be confirmed with the RCT trial. But addition to the referred outcome, the safety data is concerned in the DE surgery. So because of the very difficult surgery for the DE treatment, so maybe that is the last puzzle for the gynecology to learn how to have a DE treatment. Actually, if you know the anatomy, the space, the ligament, or the pelvic floor, then you may easily to perform the deep endometriosis surgery. We can find behind the bladder, in front of the vagina, there is the vesical vaginal space, and they have the ligament. We call it Hyphen vesical uterine ligament, and they have a right paravaginal space and the deep vesical uterine ligament just in between the right paravesical space and the right paravaginal space. And also, they have a corneal ligament just separate the paravesical space and the lateral parabrachial space. And they have a uterine ligament, have a separate the right lateral parabrachial space and the right median parabrachial space. So if you want, we have the endometriosis on the uterine ligament, we should identify right lateral parabrachial space and the right median parabrachial space, so we can dissect the uterine ligament and lesions away. And also, they have a greater the endometriosis because of the maybe vesical uterine ligament, they have adenomyosis. So we should identify the vesical vaginal space and the right paravaginal space. Then we can identify and resect the adenomyosis away. So the space and the ligament here is very important for the deep endometriosis surgery. So here is from A to Z to identify the deep endometriosis and how to resect the endometriosis. Is a 31 years old woman, and they have a little bit elevated Tier 125. And so in the sonography, they just have a small endometrioma and the left endometrioma with adenomyosis, and DE was suspected. So in the procedures, first, we can identify the tumors and identify the cortical alterations, and also identify the ureter first before you resect the tumors. Okay, here's the column also that adheres to the left side. So you should identify the median parabrachial space first, then you can identify the uterine ligament, then you can resect the adhesion over the uterine ligament. So here you just doing the adhesion like this and resect the adhesion over the uterine ligament. So here will be the prerectal space. Prerectal space just in between the two parabrachial space, median parabrachial space. So also we should identify the lateral parabrachial space. And here is the ureter, here's, and here is the deep uterine artery. And here also the uterine ligament here, and the adhesion just over the uterine ligament. So we identify the median right side parabrachial space here. And after the two parabrachial space identify, the lesion on the uterine ligament could be excited. And also the ureter was identified. Here is the prerectal space, can be identified after you have the two median parabrachial space have been identified. In these situations, the prerectal space could be identified then. So we can use the sharp scissor to dissect these fibrotic lesions. And Also, the pre-rectal space have been identified clearly. We can use the rectal probe to help us to identify the space and also the rectums. Also, here's the uterus ligament adhesions has been identified and decided. So all the lesions have been identified and resetted. So the procedure is very important. The first is to restore pelvic anatomy first before you excite the lesions. And secondly, identify uterine ligament, not adhesion meant. Also, then identify ureter. So you can identify the lateral pararectal space, also the median pararectal space. So then after the two pararectal space have identified, you can create pre-rectal space. Then you excite the deep endometriosis, and then after surgery, adhesion prevention is necessary for the procedures. So we make a conclusions because half of the women with endometriosis suffer from difficulty in conceive. So expert surgeons have showed the impact of surgery in all stages of endometriosis. It means now, even in a stage 4 endometriosis, rectal involvement of the bleeding involvement endometriosis, the expert surgeon can do a very good job in the excited lesions. And the laparoscope remains the gold standard whenever deep endometriosis surgery is indicated. ART treatment without diagnosis of the deep endometriosis decrease optimate creepage rate and is not without potential serious adverse effect. So identify the endometriosis and the deep endometriosis before ART is very important. And we should perform deep endometriosis treatment before ART if possible. Comparative sector of deep endometriosis is might minimize deep endometriosis from evolving and worsen over time, positively impact the woman's quality of life. And the approximate radicality of endometriosis surgery have achieved over the decade in expert referral center. So you had better refer to the expert referral center because of the deep endometriosis. If you're not skillful in doing the deep endometriosis surgery, maybe it's good for you to refer to the endometriosis center. The surgeon have evolved their technique based on their experience, yet continue to be the challenges by the complexity of this elusive disease process. Although the surgeons have improved the technique, but the progress of the disease is still. So we should keep in mind the principle of the surgeries. Training will be the last budget for the reproductive surgery. The best training for the best surgeon. I think that is very important for the endometriosis surgery. Lastly, we welcome you to the 2022 APAGE Annual Congress. Registrations is open already. So welcome you to submit your paper to the office and welcome you to the TAMIC and APAGE conjoint meeting 2022 from the September 30th to October 2nd. Welcome. Thank you for your attention.
I'm back. That is the video, and now you can talk to the Professor Chyi-Long Lee, the real guy, not as the AI. So Professor Chyi-Long Lee, I have my own questions.
Yes.
And your last slide, you said the training.
Yes.
But by the way, I think sometimes it's very difficult between stop the operation or advance the operation, because sometimes for the surgeon, we know that it's just one step, two steps. The outcome is maybe better, but of course it's maybe more injury.
Yes.
And that time that we are the surgeon, we are the only one who make the decision. So I think this is very difficult situation. So from your expertise, what is your advice?
Yes. Actually, as a surgeon, we always think about as a patient center. So we want to do best for the patient. So as a surgeon, always want to do some more to the patient, and they can get better outcome after our surgery. All in our mind, we were thinking about how to improve the outcome for the patient. But you know, when we do the deep endometriosis, they always have a very severe or very dense adhesion just over the intestine or over the ovary or tube. So it always have some risk. So in the early stage, just like the stage 1, stage 2 endometriosis, have obviously they have advantages over just leave it there. They have a very good result for the endoscope surgery. But to the stage 3, stage 4 endometriosis, we can find they have some complication coming out. So they always have some controversy about should we do the surgery or we just let it be there. And fortunately, they have some paper. They still favor if you can do something more to the patient, then patient will get a better outcome. So I have reviewed the paper from ZEMIC. They have talking about the review article in 4, the outstanding paper. They have talking even you did not have a complete resect of the deep endometriosis, they can have an increase in the clinical pregression rate, and also have a live birth rate will be increased. So if we can do better, of course, we should do complete resection. But if we are not able to do the complete resection, maybe we can do as possible as we can. And before we do as possible we can, we had better to have a training. And I think that is, you know, in the ERCOT, they always have some animal train and also have a cassava train in the laparoscopic surgery. So they have several times APAGE also in Thailand, the German Thai Center, we have a cassava workshop every year there, and also have a workshop of animal in the Taiwan ERCOT Center. So I think that it's very important for you to improve your skill in doing the very complicated surgery. And so I think when you have doing this procedure in the animal before doing the procedure in the patient, they will get you have confidence and also get the ability, get the power to do the surgery. I think that will be very important to every gynecologist. So I say that is a last buzzer for the gynecologist to complete. So I think the training is very important, and there are many training courses, include the animal lab and the cassava lab hosted by APAGE. I hope you can join us.
Thank you. Oh, thank you for your answer. It's very clear. So practice at the right place, maybe in Taiwan or maybe in Thailand. Yes. Okay. For the next speaker, as we know, he is the director of the Haifu, and now we move from the surgery to the non-invasive or no invasive procedure that we can use it for the treat the patient with the endometriosis. Professor Zhang Lian will talk about the comparison of the ultrasound guide Haifu for treatment the abdominal endometriosis, and he is the chief editor board member of International Journal of Hyperthermia, and of course he has a lot of the publication about the Haifu. So please, Professor Zhang Lian, over to you.
Thank you.
Okay.
So thank you, Olark. It's really my honor to have this chance to give this presentation, especially, we meet our friends. So this I'm going to talk about the comparison of Haifu and the surgery for abdominal wall endometriosis. So we all know that abdominal wall endometriosis is a real form of extrapelvic endometriosis. So, but in China, because we all know that we have a very high incidence of cesarean section, so we saw not real. Yeah, in China we saw many patients in recent years. So the symptom of this disease is a local pain at the cesarean scar incision site of abdominal wall during menstruation. So this is the most common symptom. So the treatment, so far, is still the surgery is the only curative therapy. However, the surgery is invasive, or also will cause scars, and also the surgery will perform under anesthesia. So if we can find another way to treat this kind of disease, so we think about to use this technique to use Haifu to treat this patient, because this is non-invasive, and the maybe because the disease, the abdominal wall endometriosis is very superficial, so it's very sensitive. So far, still, I think I should talk about this technique, like the high intensity focus ultrasound is a non-invasive treatment modality. This is a transducer. The ultrasound beams penetrate the generate from the surface of the transducer and focus at a very small point at some distance away from the transducer. During the treatment, the ultrasound beams focused at the target. When the temperature increased over 65 degrees, the necrosis occurred at the lesion, and we can saw the graphical changes on the monitoring ultrasound like this. So when we saw the graphical changes like this, the necrosis already occurred, because like we already see some gas in there, like just the water is boiling, some oxygen come out. So it means when we saw the graphical changes like this, they always for sure the necrosis occurred. So this technique has been used to treat a different type of solid tumors, like the uterine fibroids and also adenomyosis, also breast cancer, breast fibroadenoma, also liver tumors, pancreatic cancers, and also kidney tumors, also the bone tumors, and like even primary or bone metastasis, also uses to treat the soft tissues and also some others. For adenomyosis, I think this is a new indication. Like I just said before, because this lesion is always superficial, so it's sensitive to Haifu. But when we treat this lesion, because this treatment is under conscious sedation, so the patients is awake. So when we treat these patients, because the skin, the lesion is located in this area, so the patient will feel pain. So this most important, if we use a conscious sedation, how deep? And we must discuss with the anesthesiologist to make sure it's to use the right degree of the conscious sedation to sedative to make the patient sedative and more tolerated treatment. So because it's very superficial, the treatment, when the power we used not so high, like we use it to the power to treat uterine fibroids or liver tumor, we always use 400 watts. But for the abdominal wall endometriosis, we don't need to use so high power, and probably 200 watts is enough based on my experience, because like we use 200 watts, we can easily to see the graceful changes like this. So the only thing we should think about is that just because the treatment is under conscious sedation, usually the patient will feel the pain. So we should just give enough energy to make sure to complete ablate the lesion. Otherwise, maybe we're cause a higher recurrence rate in the future. So that's very important. But like Chyi-Long said, the training is very important also for Haifu, especially for abdominal wall endometriosis. The training is very important. So the principle of Haifu treatment for abdominal wall endometriosis is the same way, just like we treat the adenomyosis, the simple. We still like just selective ablate the lesion and minimize the size of the lesion and cause the symptom improve the symptom. For example, we saw that, and during treatment, we just like this, then this precisely and ablate the lesion to make the lesion shrink in the future and improve the symptoms. So like here is the MRI image we obtained from patients, and I can show you because it's different from surgery. If we perform surgery, just like the Abdora, for example, and then we can perform the surgical resection, remove the abdominal wall endometriosis. So, but for Haifu, it's a non-invasive. Then we can use MRI image to evaluate the treatment results. For example, like this, before Haifu treatment, we can see the lesion over here. Then one day after that, we can see there was low enhancement compared with this one. So 6 months, the patient came back, then we perform the MRI again. We can see the lesion was much smaller compared with this one day after that. And also there was low enhancement in the treated region and low recurrences. So like this, if we perform give enough power and treatment range was just right, then we can still use this way to make the curative treatment for abdominal wall endometriosis. So here, like this study is just from the Beijing, the PLA General Hospital, Dr. Wang, he performed this kind of treatment. This is the first preliminary study. So from 2007 to 2009, and 21 consecutive patients with abdominal wall endometriosis were enrolled. So you can see from this table, then the power they used from 200 watts to 400 watts. This kind of like the power they used a kind of high. So the treatment time you can see very short. The room time like just the treatment time just 13 minutes. So from 5 minutes to 48 minutes. So that's a range. So median solidification time. So because they used the higher power, so solidification time just like the median solidification time just 84 seconds. The range just from 32 to 650 seconds. So kind of short. So it's very, we still can, from this table, we can see it's easy to ablate the lesion of abdominal wall endometriosis. So about the safety. So because like I said, it's very superficial. It's if you say overtreated the lesion may cause a skin burn. So, and also use a higher power then you should be very careful. So like this study, Dr. Wang, his group, the results showed no skin burn was occurred in this study. The 21 patients, no skin burn occurred. All patients were discharged after a short observation. So during the treatment, the patient, they say the pain score is lower than 4 points. The tolerate was very good. So then the follow-up result, they show the pain didn't recur during the mean follow-up of 18.7 months. So range is 3 to 31 months. So this 21 cases had good results. So also the image showed the lesion after the treatment gradually shrank over time. So this is the image from this paper. You can see this before, just like similar to the image I showed before. So we can see the contrast enhancement was obviously the blood supply was rich in this lesion. So here, 2 months after that, we can see the treated region was getting smaller. There was low enhancement. Okay, here is the pre-HIFU treatment, the ultrasound. Here immediately after that, we can see the color Doppler showed the blood signal. Then after that, there was low blood signal on the color Doppler. So then here is another study after the preliminary study. So the other group in China, they performed the treatment like this is from Sweden Central Hospital of Sichuan Province. From 2010 to 2014, they treated 32 patients with abdominal wall endometriosis. So this is a retrospective study. Their results show this treatment parameters like the solidification power. They just used 100 watts, so much lower than Dr. Wang from Beijing they used. So you can see the solidification time. They spent like the 200 the median solidification time just 200 watts. So it's double than Dr. Wang's treatment results. So the room time was longer than Dr. Wang's study. So the total treatment time and also like the lung perfused volume ratio, it was good from this study, even they use a lower power. So about the safety, also they evaluate the adverse effects. So like this, most of the patient they used the classification from the International Society of Interventional Radiology. So like most of them were classified as class A. So 100% of the patient have the pain during the treatment, but all of them complete the treatment. Then they saw the edema of the skin in the treatment area after the treatment, like 78% of the patient had the edema in the local skin, but no other major adverse effects occurred. So low skin burn occurred, still safe in their study. So also about the volume of the lesion, they changed this. Here is pre-treatment, and 6 months after this was significant decreased. And the pain score before treatment was 6.8 points. 6 months after that, the average point score was 1.8, significant decreased. So, and this study from Sweden was just like the short-term evaluation. So here is another study, is a midterm evaluation. This study was from Beijing. And Dr. Duan Hua, I think maybe you guys already you guys knew about her. So her team did this study from March 2014 to June 2016, and they enrolled these patients, 25 cases in this study. This is about the follow-up results, like this, the score, the pain score that's before, and here 6 months is 12 months and 2 years. So from this study, like the pain score, they like 1 month, this table, they didn't show the pain score before, but 1 month was significant decreased. So 6 months after that, the pain score was kind of comparable with the study from the Zhang Lian, but 2 years, the pain disappeared. Actually, so it's very interesting. The pain score, the symptoms improved over time, but not all of them, like the pain relieved, but not disappeared right after the treatment. So here is about a shrinkage, the volume shrinkage. So 1 month after that, like the 40% from this study average, 6 months after HIFU treatment, 92%. So 2 years after that, completely disappeared. So from their study, 25 cases. This is another study about the long-term evaluation, still from Beijing, from the affiliated Beijing Intraoperative Hospital of Capital Medical University. So they enrolled 51 patients. Still, they like say 1 month, 6 months, 12 months, 2 years, 3 years, and 4 years. You can say the 51 cases after HIFU treatment, then over 2 years, they say the pain disappeared for these patients. So this followed up patient didn't report the pain recurrence. So now we should compare we already know that HIFU treatment is effective and safe. So can we compare this treatment with surgery? So here is a study from the first affiliate hospital of Chongqing Medical University, like 54 consecutive patients with abdominal wall endometriosis were enrolled, and 29 patients had a surgical resection, and 25 patients had a HIFU treatment. So then we can see the results, and here, like the technical success, both group had 100% technical success. About the treatment time, we can say almost similar. So HIFU treatment in their hospital, like 16 minutes average, and the surgery 56. So about some low significant difference. But in their study, the solution time is 287. So this study here is much higher than the other studies from Zhang Lian and even from Beijing is much longer. So they compared the intraoperative bleeding, of course, low bleeding in HIFU group, but this surgery, they should have some bleeding. And also they compared other things, I think, because it doesn't, I think we just compare the hospital stay. So after surgical resection, the hospital stay was almost 1 week. Then for HIFU in their hospital, just they stayed like the 4.4 days, and significantly shorter in HIFU group. So they also compared the cost, the cost of HIFU treatment was less in their study, but there was no significant difference. They compared, but from this table, we saw the cost was less. And about the adverse effects, they also compared. Now you can see using minor adverse events, like the HIFU group, like they had 8% had a hematuria, probably just some air bubbles in the, I think air bubbles in the bladder that cause this one. And also like the skin had some changes, five patients. But for the major invasive effects, so only the 3 cases in the surgery, but low, like this kind of, and no major invasive effects occurred in the Haifu group. So about the effectiveness, they compared the surgery. Of course, they already removed all the lesion, so completely removed. And in the Haifu group, like 92%. Okay, 92. About the symptoms improvement, both groups achieved 100% of the symptom relief. About the long-term symptom, like the midterm symptom improvement, like they follow up for the surgical treatment, like the 29 months average, but for the Haifu group is around 25 months. So no significant difference between the 2 groups. And about the recurrence rate, no significant difference between the 2 groups. It means like the effectiveness, both groups can achieve the same rate of the effectiveness. So here is another study performed from 2009 to 2015 from the third hospital of Xiangya College of Central South University, Changsha, Hunan, China. So they enrolled 51 patients in this study. They compared Haifu and surgery. So here it's like they treated 23 cases were treated with Haifu, and 28 of the patients treated with surgery. So here still they compare the bleeding. Of course, only surgical resection causes the bleeding, but the volume is not much. And the pain score after Haifu, immediately after Haifu, the pain score in the surgical resection group, of course, is significantly higher. And the hospital stay in their center. So the Haifu group stayed for 5 days, and the surgical resection group just stayed for 8 days. So there is a significant difference between the 2 groups. Yeah. So this is about the size changes and the pain score changes after that. So first we see the pain score changes like the 1 month after the treatment, the Haifu group just 1 point. And of course the surgery group the same. And the 2 months, 3 months, 6 months, and 12 months. And 2 groups about the same. So there was no significant difference between the pain score changes after the treatment. So about the size of that, of course, after the surgery, they have no lesion after that. But here, they gradually shrank. So only 6 months, so there were significant differences. That makes sense, but we should say the long term, just like the previous study already showed. So here is about the summary, and Haifu treatment, like as a non-invasive treatment, already show it's a promising, and I think we can use this technique to treat the abdominal wall endometriosis. So because the effectiveness of Haifu treatment is comparable with surgery, but with less adverse effects and short hospital stay. So only the problem is right now is that they study because the patient like is not so many. Okay, they like this study, the sample size was small, and also like I think if we compare with surgery, because the Haifu already showed the non-invasive and the treatment with less adverse effects and a short hospital stay. So I think the retrospective study already show the results comparable. So I think like in the future, we can perform the randomized clinical study to compare, to confirm if Haifu can reach the same results like the surgery So that's what I want to share with you, and thank you very much.
Hi, thank you very much, Professor Zhang Lian. So this is very interesting procedure to treat the patient. And in my opinion, I think this is the best way for me to do the procedure, because sometimes when I do the surgery for the abdominal wall endometriosis, I cannot find the lesion, right? Do the incision and use the finger to find where is the lesion, because sometimes it's very small, like 1 centimeter or 2 centimeters, and the belly, the abdominal wall of the patient is really thick. So sometimes it's very difficult to find where is the lesion. But if we use the Haifu, it's a real-time ultrasound.
Yes.
So that we can find the lesion in one time, right? In one time. And of course, maybe it's use less time to reach the target. So very, very interesting. So if I have the chance, I will use it for treat this kind of the patient. That is my comment. And now we don't have the question, so we can move to the next speaker.
Okay, thanks.
Okay, thank you. And of course, for the last session, we have all of the three speakers to join the session and give a talk. And now this is my co-chair, Professor Relly, is now. Hi, Professor Relly.
Hi, sorry I'm late because I have another conference in Morocco.
Okay.
So,
in Morocco, I'm in A10. I'm in A10, Greece. So the meeting the first time we met in the CEUD meeting, like in Barcelona, like 6 years ago, I think.
Yeah. I think
so.
It's
Please,
the first
Professor Relly, over to you.
Okay, thank you, Dr. Olark, for your has already lead the discussion, lead the discussion on the previous session. So regarding for the organizing, I have to lead the last session of the Haifu conference. Now we have maybe the last speaker, Dr. Hyphen. He will talk about learning curve of Haifu in training experiences in China. So before she will give a lecture, I will introduce her. Dr. Hyphen is the Director of Training Department, Engineering Research Center of Ultrasound Medicine, China. She is also Senior Training Lecturer, High Intensive Focus Ultrasound Training based on China, and International Society of Minimal Invasive and Virtual Surgery, and has successfully provide clinical technical guidance and physician training for ultrasound ablation treatment in the hospital, at home, and abroad, including South Africa, Argentina, Hong Kong, Spain, and etc. And also she has a lot of publication has already published by her, and internationally and nationally journal. Now this time is yours, Dr. Min. Please, time for you to talk.
Okay. Thanks for the introduction. Okay, I'm glad to give this this lecture tonight. Okay. So can you see my screen?
Yeah.
Okay,
Clearly.
thank you. Yeah, thank you. My topic tonight is the learning curve of Haifu and our training experience in China. At the beginning, let's see these videos. This video show us the traditional 3 kinds of treatment methods. The first one is traditional open surgery, and the second one is laparoscopic surgery, and the third one is Haifu. These videos, this methods, this treatments represents the evolution of surgery in recent 200 years. And we can see there is a lot of differences between among these 3 kinds of methods. And after the treatment, we can see the skin. The abdominal wall is very different. For the traditional surgery, we can see there is a big scar on the abdominal wall. And for the laparoscopic surgery, there is only 3 small holes, small scar. But for Haifu, the abdominal wall is very smooth. It's wonderful. And for the uterus, we can see the first two kinds of surgery. The scar on the uterus is very, very large. And for the Haifu, there is no damage for Haifu. So, as doctors, which kind of treatments, which kind of surgery do you like? Which is your favorite? And also, if you are patient, which one are you willing to choose? So we talk about the learning curve of Haifu tonight. So at first, we should know what are the characteristics of Haifu. The first characteristic is non-invasive. There is no damage for the organs, for the abdominal wall. And the second characteristic is image guidance. That means we can use ultrasonic or MRI image to guidance the whole procedure. The third one is real-time monitoring. This means through real-time monitoring, under the ultrasonic monitoring mode, we can judge the treatment effects according to the change of the grayscale changes and the focus. And if we use MRI guidance, we can follow the change of temperature and the focus to judge the treatment effects. So what are the indications of Haifu? Professor Zhang Lian just showed us we can do benign and malignant solid tumors. That means breast, liver, kidney, pancreas, or uterus, we can do this. In other words, as long as we can establish a safe acoustic pathway here, we can treat the solid tumors. So according to different surgical methods, the requirements for learning doctors are also different. We usually use a learning curve to discuss the mastery of our technology. So what is learning curve for doctors? The learning curve is defined as a graphic representation of performance against experience. It plays an important role in deciding when trainees can. The first one is operates independently. The second starts performing more complex cases in a safe manner and achieve better patient outcomes. So according to these requirements, what are the basic requirements for doctors to learn Haifu? We know that all the doctors from clinic-based major can do this treatment. That means gynecologists and obstetrics, oncology, surgery, breast surgery, also medical imaging. So all the clinic-based major can do Haifu. And the second requirement is that the doctor needs some image recognition ability, both ultrasound and MRI. The third requirement is that we need to have some understanding of Haifu. So all clinic doctors can learn Haifu, but doctors with different backgrounds has their own characteristics. For example, gynecologists are familiar with imaging anatomy and have strong ability in practice. And for radiologists are familiar with application of ultrasonic operation. And there is some difference between traditional surgery and Haifu, and all between the traditional diagnostic ultrasonic imaging. The transducer of Haifu system is bottom mounted. The image is displayed in the opposite direction during Haifu. So we need to talk about the factors affecting the Haifu doctor's learning curve. According to our experience, the ultrasonic image recognition ability is very important. It's a basic requirement, and also clinic experience and Haifu treatments related knowledge. Also, what affects the learning curve directly is the number of cases the doctors do, and also the operation frequency. So what are the indications we use to evaluate the learning effects of doctors? We use the sonication time, treatment time, MTV ratio to evaluate if the Haifu treatment is effective, and we also use serious or major complications to evaluate the treatment if safe. So according to our experience in China, since in 2005, the high-intent focus ultrasound tumor treatment training base was established by Chinese government. And since 2005, we began to train Haifu doctors, and we also found some problems in this process. So therefore, in 2018, we set up a special training center in Chongqing. In this center, we built a training platform for simulated images and simulators based on image viewing and computer digital technology. And we also established the Haifu parallel system combined with real-time surgery sensories in clinic centers, realizing one-to-many clinic instruction. Okay, this is our training mode. This is our training system. This includes 2 weeks theoretical study and 10 weeks clinic study. For these 2 parts, our doctors can accompany 30 to 40 cases, and when this 12 weeks study is over, almost all the doctors can do Haifu treatments independently. And they will also have another system to support the training. For example, on-site support or remote support will do some upgrade classes when there is some necessary. And these are some of our 2 weeks training content. This includes Haifu treatment system and working principle, biologic effects and mechanism, and minimally invasive and non-invasive concepts and clinic thinking training, EMG regulation, ability, ultrasound-guided focused ultrasound surgery operation training, and also the most important one, the prevention and management of complications. And after all of these classes, we take some assessments and do some evaluation for doctors. These are some of our lessons. Now we can say we have a classroom that can accommodate 30 people to set in, and our set of Haifu treatment system only for teaching, only for training. And we also have a human models, and these human models can give us the opportunity to simulate the Haifu procedure. There is a picture from our lesson, our theoretic teaching. And for this one, we just use the Haifu system for ox liver experiments that can show how necrosis causes. And this passage show us there is some necrosis in the ox liver. And also we use the human models, and in the pelvic of this human models, we see some phantom that is simulated as fibers. And we can use this unit to simulate the Haifu procedure. Then our trainees just sit from here and just do the whole procedure, just like we do Haifu treatment for patients. And we can see this phantom is before Haifu, and this one is after Haifu. If the trainees can cause the necrosis like this in the phantom, that means he or she just do the right procedure. And there is some difficulties for our clinic doctors because they don't have enough image regulation ability. So we use the ultrasonic and MR image filling technology. Then for this system can shorten the learning time. And we also have a parallel operating room. These two screens can show the treatment real time in our treatment room, and then our teachers just stand here to explain the whole procedure and answer the questions of our trainings. So we can teach more than one doctors one time. And we also have the opportunities to enter the operating room to learning and to observe the real treatment and the reaction of the patients. And also our teachers can explain how to operate, how to do the Haifu, how to do the procedures, and how to deal with the reaction of patients. After these 2 weeks theoretic training, our doctors, our trainees will go to the clinic training bases. We have 20 clinic training bases, and one of these training bases are from the top hospitals in China. Its clinic training center has more than 2,000 cases of Haifu treatment, and almost all of them have no serious complications during their work. So this is the first stage training. That includes 2 weeks basic theory training and 10 weeks clinic operation. And during this period, they can almost all the doctors can finish 30 to 40 patients have treatment. And after the training, we do some evaluation. If they pass the examination, they can obtain certificate. And this means that they can do Haifu treatment independently. And if necessary, after the first stage, our doctors just go back to their own hospital and do the Haifu treatments by themselves. But if necessary, if they make some very difficult with complex, very special patients, we can use a telemedicine center. This telemedicine center can connect globally. So if you need, we can help. So according since 2005, 2,150 professional doctors have been completed the basic survey trainings, and 1,726 come from China, and 414 came from abroad. And during of these 2,150 doctors, 425 doctors completed the HIFU training process and obtained certificates of HIFU. We can see since 2015, we only have 16 doctors have obtained the qualification certificate, but to 2021, there is over about 130 doctors. We analyzed the learning situation of these 412 doctors with the qualification certificate. We found that before 2018, the average learning time was 5.6 months. The average number of patients treated during the period of training was 70, but after 2018, the average learning time was only 2.6 months, and the patients was only 54. Why this happened? Because during the training procedure, we found something is not so good. So we established the training center in 2018. So this is a change. And we also found that the treatment time tended to be stable after the training. After the training completed 39 patients. And also the sonication time want to be stable after the training completed for 34 patients. So, and also the operation frequency affects the learning curve very much. We can see the learning curve of the Dr. A for this part. We can see that Dr. A only do 2 patients per month, but Dr. B do 7 patients per month. So there is some difference between a lot of difference between them. We can see that for Dr. Z, the function between acceptable H0 here is 33, but for the Dr. B, when the doctor finished 13 patients treatment, we can see this line is just crossed down H0 here. That means his treatment is stable. And we can see that when this is show the patients we treated by Haifu for this year. So we can see the increase of number of patients treated with Haifu year is increased very much year by year. And we analyzed these reasons why this happened. The first is development of Haifu system. This is the key factor. And also the improvement of clinic protocol. This is also very important. And also more and more doctors are involved and receive the systematic training. So maybe we are not of people want doubt the results of the trainings, the new doctors treatments. So we are also very concerned about this. So we did 2 retrospective studies. All this data are come from our clinic training basis. So this data can well show the operation results during doctor's learning curve. So for the first study, we analyzed the 10 centers, including 10,018 cases. This is from 2006 to 2013. We can see that the average twist time for uterine fibroids is 1,243 seconds, and the NPV ratio is 8.3. And for the side effects, we can see that there is the total side effects is 10.6%, and for the class grade A is 95%, and class B 3.4, and class C and class D is 0.45%. And in another study with retrospective on side effects, this includes 27,053 cases. This study analyzed the data from 2011 to 2017. We can see the treatment time is much shorter, it's only 72, and the sonication time is only 607 seconds, and the NPV ratio is 85%. So the side effects, we can see that the class A, there is only 47, and class B is only 0.79. I do some comparison behind. We can say this is the serious side effects happened in these years. This is the proportion of severe complication of grade C and above. We can see since 2011 to 2017, it's decreased very much. And this is another included from the 2009 to 2020. We can see the severe incidence, the serious adverse effects is below the 0.5%. So I do some comparison here. From these two studies, we can see that the side effects is decreased very much, and also the treatment results, the sonication time, the treatment time is decreased. So that means our training is effective and safety. So I do some conclusion here. Doctors can achieve the standard of independent treatments by completing Haifu treatments of 30 to 40 patients. This means even the junior doctors who have just graduated from medical school, they finish 30 to 40 patients. They have no clinic experience. They can do Haifu treatments independently. And the treatment frequency is one of the main factors affecting doctors' learning curve. Centralized and systematic training can greatly shorten the learning time. Clinic experience will affect the learning curve of Haifu doctors. The doctors who with more clinic experience have shorter learning time. Okay, thank you so much. This is my sharing.
Okay, thank you, Dr. Min, for your nice presentation about the learning curve of the doctor who learned the Haifu treatment. So we can open for the discussion. Is there any question from audience?
Hi, I have some questions. May I have questions?
Yes, please, Dr. Rahmat.
So of course, we know that now is there's a COVID infection all over the world. So how about the protocol if we want to enter the China to do the training? Do I have do the quarantine, something like that?
You mean, pardon, sorry. You mean you want to come to Chongqing?
Yes. If we want to go to the Chongqing to do the training because we know that learn from the expert is the best. Okay, we have the telemedicine, but it's not same as face-to-face training, right? We all know that. So what is the protocol in China for now?
So first, I show our welcome for you. We welcome you to come to Chongqing. I think you have the country. You have the country come to here. If you are qualified doctors in your country, you can come to Chongqing to do some face-to-face training, because you learn this and you can do Haifu in your country, not in China.
So please, I think Professor Zhang Lian would like to share about this.
So I'm very glad to, to answer your question, Olark. So really, I hope like next year, we can see you in Chongqing. But so far, I mean, like I just came back from America. So even when I come back, I had to have 2 weeks isolation. Then I have to stay in my home for another 1 week. So about 3 weeks. So far the policy didn't change. Probably next year, I think, because I'm confident next year this will be changed. So then you can, I really want to see my friends like you guys. So I want to travel to Thailand, Indonesia or something to meet you guys too. So I think so far in this technique right now, I mean, is mature, and the way even in China now we treat even right now in my Haifu hospital. So every day we average, even like the COVID-19 pandemic right now, I think we have very strict policy, but every day we still treat like around 5 cases. So I hope if you guys have the chance to come to Chongqing, I think it's easier for you to master this technique, and to when you, I mean, after 1 month or something, you can come back to treat the patient by yourselves.
Okay, thank you. For how about in Taiwan? How about in Changchun?
Yes, I have some edit there. Because Zhang Lian is the chairman of the training committee, and we plan in the APAGE, they have some overseas the training center. That is when some guy they can come in to China, then, or maybe they just locate in Singapore, locate in Thailand or in the Malaysia. They have some training center will be set up. One will be in Singapore. That is the Dr. Relly Yanuari, and the second will be in Taiwan, but they are not settled down yet. And another in Hong Kong. And so maybe recently we were talking about another one in Malaysia. So in the near future, I think if they are still not available for Chongqing, I think the Chongqing is the best place, because they are a very huge amount of the so experienced surgeon, experienced Haifu doctor there. So I think that is the best place to train. But in the basic course, or you just need to have initialized the experience. Maybe you can choose the overseas the training centers, just like in Singapore, in Taiwan, or in Malaysia. They will be established maybe next year or the end of this year. It should be supervised by the Dr. Zhang Lian. Yes, I think if we can have some audit on the center, that would be good for every overseas doctor to have a basic training and just you need to have a advanced course, then you can go to Chongqing after the quarantine have been complete, or they have not need to have any quarantine anymore. Yes.
Yeah, I think it's a very great idea, probably, to spreading the training center of the Haifu.
Yes.
Because more closer for the doctor place for hospital is getting more cheaper for the doctor come to the training center. Especially yes. For the COVID pandemic situation, this is a lot of doctors still awareness of the infection. So most of them still wait and see to get training on the China. I think it's very, very nice idea. Hopefully on the short time, the training center outside of the China will be held it and open it, and more doctors will be around the world learn about the Haifu.
Yes.
Yeah. Is there any question?
For now, there is no question. But by the way, I would like to tell everybody, invite everybody that for the next webinar, also very, very interesting, especially for the cesarean scar surgery. Wow, this is very, in Thailand, the C-section rate is around 60%. 60. Oh. That we have a lot of the cases that there is a cesarean scar defect. So, wow. So I think this is very useful for us. And in Thailand now we have the study with the WHO to plan to decrease the number of unnecessary C-section because it's too high, right? It's 60%. That's too high. So we plan to. So I would like to invite all of the participants to join. The next session is on 16 June.
Yeah. Yes.
Bye-bye.
Yes.
Bye-bye.
Yes.
ใจเจียน สวัสดีครับ
再见。
สวัสดีครับ สวัสดีครับ Yes. Yes. Okay.